We are live now.
Sir, we are live now. Sir, shall we start?
Yeah.
So, good evening, doctors and all the participants. Shuman, on behalf of Child Healthcare, welcome you all in today's session on a very important topic that is dengue is threat to society. As we all know, these vector-borne diseases are posing a great risk to our society in recent times. So we have with us today Dr. Rabindra Yadhav, sir. Although sir doesn't need any kind of introduction, but it's my formal responsibility to introduce sir. Sir did his M.B.B.S. PG diploma in Maternal and Child Health. Sir is working as a district vector-borne disease control officer in SITAMARHI, Department of Health and Government of Bihar. In terms of other social activities, sir is already attached with many activities as well, and sir has presented many papers in national and international level in vector-borne disease. So with this short introduction, I request sir to take over the session, and meanwhile I request all the participants for their active participation, and please post your queries on the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic itself. So thank you very much, sir, for your valuable time. Over to you for further questions. Thank you very much.
Yeah, thank you, Sumanji, and all your SEAL team for giving me this opportunity to present this nice topic. Dengue is no more an uncommon disease, and now it is very common, and particularly as the spread is taking worldwide. Previously, it was limited to only urban cities, but now, day by day, as we are observing, it is just going to the suburb as well. Maybe due to expansion of this urbanization to the village people. So this time also it has taken an outbreak. So it's a need of the time to deal with such a good topic, dengue, a threat to society. Really, it is going to be the threat to society. So let us go with this disease, what this disease and how we can manage in a simple way.
Click on the slide on this.
Yeah, so it's a infection, not only limited to the, it is limited to the tropical and subtropical region, and it ranges from non-specific febrile illness to fatal hemorrhagic disease, and it is caused by a virus and is spread by a vector, that is mosquito. So dengue fever is a viral disease caused by a virus, that is dengue virus. 4 types of this flavivirus group. This belongs to RNA virus, and vector being the Aedes mosquito, mostly the Aedes aegyptis, though in some part albopictus is also, but it's commonly Aedes aegyptis, and vector gets transmitted throughout the India, and most of the states are now observing this dengue endemic. So it's a very common nowadays. Early detection and access to proper medical care may reduce the fatality of this disease from 20% to 1%. So what type of this dengue virus is? Dengue virus usually is RNA virus and have 4 serotypes, dengue 1, 2, 3, 4. Each serotype provides a specific lifetime immunity, and short-term cross immunity is also there. All serotype can cause severe and fatal disease. This is very important. Genetic variation within serotypes, some appear to be more virulent or have greater epidemic potential, but all serotypes can produce outbreaks and epidemic. What are the factors responsible for this rapid spread? Why it is spreading so widely nowadays? Unprecedented population growth is certainly the important factor. Unplanned urbanization is the most important factor because there is more and more mosquito breeding site, inadequate water and waste management, increased distribution and density of vectors, and lack of effective control of these vectors is very important. So all together are responsible for rapid spread of this dengue disease. Why it is spreading so widely? Dengue virus causes symptomatic infection as well as asymptomatic seroconversions. And patients with asymptomatic infections, which are viremic, are very important source of infection. So that cannot be ignored of. So these asymptomatic patients are mostly responsible for this spread. Dengue fever, so far epidemiology is concerned, mosquito-borne disease, it's a viral disease. And as I discussed, Aedes aegypti is the mosquito responsible. And it is being transmitted by the infected bite of this Aedes mosquito. WHO estimates globally 50 to 100 million cases in more than 100 endemic countries. And nowadays, even countries are increasing, and it has increased up to 130 country now just witnessing this dengue disease. Mostly the countries are of Africa, America, Eastern Mediterranean, Southeast Asia, and Western Pacific region. Dengue hemorrhagic fever is the very dangerous type of this dengue disease, and which accounts about 250,000 to 500,000 cases in 24 and about 24,000 deaths each year. 30-fold increase in global incidence over the last 5 decades. So this is very remarkable changes, and as we are seeing the vast urbanization day by day, increasing urbanization of the villages, and the villages are adopting the urban culture. So is the spread of the disease, and 30-fold increase in only in 5 decades is very concerned with. And that's why it's very important to talk of this today's talk. Dengue, India, so far it is concerned, first it was isolated in Calcutta in 1945. Extensive epidemic since 1963. Almost every 10 years, this epidemic spread was taking previously. But now in previous few years, we have noticed a closer at a increased frequency of this epidemic outbreak. Severe epidemic in Delhi was noticed in 96, and there were in 2006 and 2012. In Lucknow, it was also noticed in 1998, 2003, 2006, and in Bihar, Patna, 2019, and this year also Bihar has witnessed a vast this epidemic outbreak. In total Bihar, it is more than 13,000 cases has been reported, and particularly in Patna, it is about 10,000. So it's a matter of concern. All 4 serotypes are prevalent here in India, and virus prevalent all over except Himalayan region and Kashmir. So you can say pan-India, it is almost all over, all states are witnessing it. So far incidences are concerned, pooled estimate of seroconversion. Seroprevalent cases are more, it is 56.9%, and case fatality is 2.6%. Proportion of primary and secondary dengue infection among lab confirmed diagnosis, it is 42.9 is to 57.1. It is the lab confirmed cases. And distribution of predominant and co-circulating dengue virus serotypes, it is in all India, all the types of all the 4 serotypes are prevalent, but mostly dengue virus 2 and 3 are common. So our genomic structure of this flavivirus is concerned. Dengue virus is a positive stranded encapsulated RNA virus, belongs to flavivirus genus of Flaviviridae family. The genomic RNA is approximately 11 kb in length, composed of 3 structural proteins: viral genome, nucleocapsids, ENM protein, viral envelope. These are shown in the figures. And these non-structured protein are assumed to be involved in the replication of viral RNA and thus form the diagnostic basis of this NS1 antigen. Pathogenesis and immunity of dengue after inoculation by the infected mosquito. The virus spreads rapidly in the regional lymph nodes, replicates primarily in the phagocytic macrophages and monocytes, also possibly in various lymphocytes population as well. Viremia begins in 3 to 7 days. 3 to 7 days after the onset of fever, this viremia is there. Infection takes place, and on 3rd to 7th day, this viremia persists. And during this viremic phase, if mosquito and virus get transmitted, firstly this infected mosquito, when it bites a human being, through this saliva, it enters and virus replicates in the target organs. Virus infects white blood cells and lymphatic tissues. Virus released into the blood, and the viremic phase comes. And when second mosquito ingests virus with blood, virus replicates in mosquito midgut and other organ, infects salivary gland. Virus replicates in salivary gland. And this shows the intrinsic and extrinsic incubation period, mosquito bite to viremia, and it takes 0 to 5 days, and then up to 12 days it is the extrinsic phase. And when another mosquito refeeds, then transmits virus, and again this viremic phase takes place. So far, prevalence and inhabitants of these habitats of this Aegypti is concerned. It usually it is not in dirty water always, but sometimes it is prevalent. It breeds in clean water as well, in domestic uses water, domestic wastes, and particularly it inhabits in thrown away tires, coolers, and these earthen pots, buckets, and whatever things spreaded unused on rooftops. And when after rainy season, when this gets filled with water, here it can breed. So it's a container breed. Even a small amount of water can be even in a small amount of water, these Aedes can grow, and that can breed. So this is of importance while how we can prevent. Symptomatic dengue infection. This can be divided in 3 parts: undifferentiated fever, that is recognized by maculopapular rash; dengue fever, it may be without hemorrhage or with hemorrhage; and the dreadful dengue hemorrhagic fever. This dengue hemorrhagic fever may be with shock or without shock. When it is with shock, it is known as dengue shock syndrome. WHO lab criteria for dengue infection, it has been just established that 2 parts, you can say. It's a probable case or confirmed case. For confirmed case, you will have to isolate this virus from serum, autopsy specimen, demonstration of dengue virus antigen, and CSF, or from autopsy tissue, and detection of dengue virus genome by PCR. But probable cases, because everywhere these facilities are not available, so we will have to go with the probable case diagnosis, and this includes clinical features with supportive serology. Supportive serology means increased titer comparable IgG, ELISA, or positive IgM. Dengue fever. Symptomatic dengue infection is a systemic dynamic disease and clinical spectrum that includes both severe and non-severe clinical features. The incubation periods last for 5 to 7 days, and the onset of illness is abrupt. Common presenting symptoms include high grade of fever, headache, retroorbital pain, myalgia, arthralgia, nausea, vomiting, and rash. The symptoms usually last for 2 to 7 days. Usually, most of the cases, it resides by 7 days. Three phases comes. Dengue fever goes through 3 phases. First one is febrile phase, and second is critical, and then the recovery phase, the convalescent phase. The severity of the disease becomes apparent during defervescence transition from the febrile to afebrile phase. Increased capillary permeability that lasts approximately for 24 to 40 hours is the more common in secondary dengue infection, and it is very dangerous. So if we go through this graphical pattern 4 to 10 days after mosquito bite, how it comes, temperature rises up to 40 degrees centigrade. From day 1, it started rising, and it go up in the second day. So first 3 days, it is the febrile phase, and second one, this is fever goes down, but shock may start. It is in the critical phase, and from day 7 to 10, you can treat as recovery phase. So in first 3 days, temperature go rise, and potential clinical issues is dehydration there. But in critical phase, the potential issue is shock, because here capillary permeability, and there may be shock, and it transfers to the extravascular compartment. So organ impairment is chances. There is chances of organ impairment in this phase. So this is very critical phase, and you have to take care of. And then in recovery phase, there is reabsorption of the fluid overload, and patient recovers. Laboratory changes, so far it is concerned. In critical phase, it is the hematocrit that goes rising. And this is very remarkable. If you notice early rising of this hematocrit, you can just notice this critical phase, and you can manage as well. And then patient can go into this recovery phase. So critical phase is important by increased hematocrits, and serology and virology continue. So first 3 days, there is a viremia phase, and then gradually there is a declination in virus, and then gradually this antibody IgM and IgG goes on rising. So dengue viral infection, you can divide it in 2 groups, asymptomatic and symptomatic. So 80% is asymptomatic usually, and 20% are symptomatic. Out of this symptomatic, there may be undifferentiated febrile illness, dengue fever, dengue hemorrhagic fever, plasma leakage is hallmark as in the critical phase, and compensated normotensive shock. And if it is not managed properly, then it may lead to that, it may pass to hypotensive shock, that may be dangerous and fatal to the person. So course of dengue illness, we can divide in febrile or viremic phase, critical phase, recovery phase. In febrile phase, it lasts for 2 to 7 days. Symptoms are headache, myalgia, arthralgia, retroorbital pain. This is very important, particularly in case of the retroorbital pain. Children may have anorexia or nausea and vomiting. Progressive disease in WBC, the total count is just below 5,000. There is leukopenia, and mid thrombocytopenia plus mild hemorrhage may take place, and mild thrombocytopenia in this febrile phase may take place. And if you go for a tourniquet test, it is positive. It is positive in viremic phase. So far critical phase is concerned, warning signs between days 3 and 7 of illness, increased capillary permeability causing plasma leakage. This is very important, and you must take care of if this is the phase where it requires a rehydration, and fluid therapy is important. A rising hematocrit is the early sign of plasma leakage. Shock from plasma leakage, severe hemorrhage, and organ impairment you should take care of. And one must look for the signs and features of this. So for recovery phase is concerned, gradually the fluids get reabsorbed in the vascular compartment. Compartment fluid takes place in following 48 to 72 hours. General well-being improves, and fluid overload may happen if one should be aware of that there is a reabsorption of this extravasated fluid. So gradually you should go down with, if you are on intravenous therapy, if you don't just reduce the rate of infusion, or you don't reduce this transfusion, then fluid overload may take place, and sometimes it may lead to pulmonary edema and hypervolemia that may be fatal. So this is a demonstration of Turnic test, how you can test. Simply, it's very simple. Firstly, you take the BP of the patients, you mark the systolic and diastolic pressure, and then just inflate this in between. Suppose the systolic pressure is 120 and diastolic is 80, then the midway will be 100. So just inflate for 5 minutes, inflate the BP curve for 5 minutes, and observe for any petechial changes. If there is petechial hemorrhage, particularly in 1 square inch, if there is more than 10 petechies, then it is considered as positive, and that is matter of that helps in diagnosis. Its sensitivity is 40% and specificity is 95%, as reported by some group. So these are the other features are in dengue patients. You can have macropapular rash as shown in the figure, and this finger impression, if you put a finger, it may give impression there, and sometimes while examining by the doctors, it gives the stetho impressions. Clinical evaluation, history taking, clinical examination, investigation, diagnosis, and assessment. So let us take one by one. Step 1, patient's history to be asked. This is very important. If a careful history is taken, then you may diagnose it, because always it is not possible to go for the lab diagnosis. Date of onset of fever, it is very important. Date is preferable to the number of day of fever, because you can correlate with in which phase this dengue fever is. A history of dengue fever among households and neighbors living in the recent travel. So if in a society, in a community, dengue is diagnosed, then other flu-like fevers may be considered as dengue. And if there is a history of travel in an endemic zone, or where there is an epidemic outburst of this dengue, that also must be considered. History of chills, rash, facial flush, retroorbital headache, arthralgia is very important, and it is particularly important for this dengue. Persistent vomiting, diarrhea, pain, abdomen, it is very important, because it is persistent vomiting is one of warning signs. Shortness of breath, bleeding from any orifice, like or a nasal, in a mucosal part, or it may be from a gut, or it may be from nasal bleeding. Anywhere it can bleed. Reduce urine output, cold peripheries, it is very important. Profuse sweating, postural dizziness, blurring of vision, yellow discoloration of skin and mucosa, that are symbolic of this shock. So it's very important to ask these 3 golden questions: oral fluid intake quantity and type of fluids, urine output, quantity in terms of frequency and estimated volume of the urine, most recent voiding, types of activities performed during this illness, can the child, whether they are walking, they are moving, they are taking parts in play, or going to school, work, market. Though it is not important, but it indirectly gives you assessment regarding patient's hydration and status, clinical status. whether patient is able to cope with the disease or not. Uh, Other fluid losses such as vomiting or diarrhea, presence of warning signs, particularly after first 72 hours of fever, if there is massive vomiting, then it is a matter of concern. Medication, including non-prescription or traditional medicines. Sometimes people are also taking some traditional medicines in dengue. So that also must be taken account of in the history, and in use the time they were last taken, when they have taken last. Risk factors that other suppose patient is having the diabetic group, or patient is elderly, patient is pregnant. These are the risk factors that you must consider in the history. And step 2, when you go for clinical examination and assessment, assess temperature, blood pressure, mental state, maculopapular or macular confluent rashes, conjunctiva, hydration status. These must be noticed. And peripheral perfusion status must be assessed. Patient's hand and assess this peripheral part by color, this CCTVR, color, capillary refill time, temperature of the extremities, pulse volume, and pulse rate. If there is capillary refilling below 2 seconds, then it's good. But it is, if it is beyond 2 seconds or between 2 to 3 seconds, it can be considered moderate, but more than 3 seconds is alarming. Tachypnea, acidosis, acidotic breathing, pleural effusion, abdominal tenderness, hematological hepatomegaly, ascites, tourniquet test repeat if previously negative, and examine top shift. Warning signs in dengue, these are very important. Some important warning signs: bleeding, suppose there is epistaxis, bleeding from nose, scanty hemoptysis, hematemesis, gum bleeding, colored stool, excessive menstrual bleeding, dark colored urine in hematuria. These are of concern. Lethargy or restlessness, sudden behavioral changes, convulsion, difficulty in breathing or palpitation or breathlessness, persistent vomiting more than 3 times a day. It is to be noticed. Severe abdominal pain. It is also important signs as well as symptoms. Postural hypotension, when patient sits or patient stands and gets dizziness. This also reflects this shock status. Pale, cold, clammy skin, cold, clammy extremities must be noticed, whether the patient is passing into shock or not. Not able to drink or no urine output for 4 to 6 hours, and particularly if it is less than 0.5 milligram per kg per hour, it is matter of concern. Warning signs in dengue fever, additional danger signs for clinician: enlarged and tender liver. This is very important sign one must look for. Rising hematocrit together with rapid fall in platelet count shows the patient is in critical stage. Metabolic acidosis, dearrangement of liver, kidney function tests, pleural effusion, ascites, gallbladder edema clinically or by imaging. These are the features, these are the warning signs. Key points, warning signs between day 3 and 7, as I described earlier. This is the phase of critical phase. So this is very important. If the warning sign appears in this between 3rd to 7 days. Increased capillary permeability causing plasma leakage is the main pathophysiology here, because due to this capillary leakage, fluid passes from intravascular compartment to extravascular compartment, and here it needs some compensation by these intravenous fluids. Arising hematocrits in early sign of the plasma leakage. As we discussed earlier, we must do the this hematocrit value, particularly in between day 3 to day 7. Laboratory diagnosis of dengue viruses, this NS1 antigen detection, serology, the study of diagnosis of disease by measuring antibody, referred to as serology. IgM, captured enzyme-linked immunosorbent assay, MAC-ELISA. Heme agglutination inhibition, neutralization, indirect IgG-ELISA, rapid test, RT-PCR and real-time RT-PCR, virus isolation and culture. And particularly so far as specificity is concerned, this virus isolation is the best, but the facilities are not available everywhere. And this serology by IgG, IgM, you can diagnose most of the cases, though specificity is a little bit less. But in epidemic outbreak, where mass of the population has to be screened, these are of use. Other required investigation as per clinical judgment: complete blood count, blood sugar, liver function test, kidney function test, serum amylase, lipase, serum electrolytes, cardiac enzymes, chest X-ray, ultrasonography of abdomen, ABG, bicarbonate or lactate electrocardiogram, depending upon the facilities you should go for. Collection, storage, and transportation of sample is very important. 3 to 5 ml clotted blood to be collected in screw caps, and all samples to be transported only in cold chain. So this cold chain transportation is very important. Appropriate labeling is most important. Serum must be separated before transportation, and no frozen blood should be transferred. Transported. Assessment, management assessment, presumptive diagnosis. So firstly, we will have to go for this presumptive diagnosis. If a patient lives in or has traveled to the endemic area, plus fever and two of the following. Two of the following means nausea and vomiting, rash, aches and pains, headaches, or warning signs, tourniquet test positive, leukopenia. If either of the two with fever and patients lives in this endemic area where confirmative cases of dengue, whether the patient has traveled to that area, these together makes the presumptive diagnosis of dengue. Warning signs concern severe abdominal pain or tenderness, persistent vomiting, mucosal bleeding, liver enlargement more than 2 centimeters, clinical fluid accumulation, lethargy, restlessness, increase in hematocrit. These are the warning signs. So either one of the warning signs or this clinical features together, we can form the presumptive diagnosis. If there is warning sign, no warning sign, you can divide it in 3 groups. These patients can be divided into 3 groups depending upon the warning signs and the other features, clinical features, and accordingly they will be managed. So group A consists of no warning signs. Means patients have only clinical features, there are no warning signs, absence of warning signs. So these patients are group A patients and can be managed on outpatient department. And group B patients are those patients with warning signs, severe dengue or coexisting conditions like pregnancy, infancy, diabetes mellitus, poor social situation, old age, renal failure. These type of patients need some extra care. So this requires inpatient management. So this type of patients can be admitted, and these are the group B patients. And group C patients are those patients with severe plasma leakage with shock, a dengue hemorrhagic shock, severe bleeding, severe organ impairment. These requires tertiary management in the well-equipped hospitals where there's plasma transfusion facilities and all the tertiary care facilities are available. So these patient from management point of view, patient can be divided into 3 groups: Group A, Group B. Group A should you can manage on outpatient department, and Group B in inpatient department get admitted, and Group C only in the well-equipped hospital. Clinical course of illness, dengue fever happens in 3 stages. So earlier we have discussed febrile stage, critical phase, and the recovery phase. So febrile phase, it is between day 1 to day 7 usually. High grade fever, facial flushing, skin erythema, body ache, myalgia, arthralgia, retroorbital pain, headache, anorexia, nausea, vomiting, rash, and sometimes confluent rash. These type of and these rash may look like measles. So these type of patients are in febrile phase. In critical phase, that lasts usually between day 3 to day 8 or day 7. These are the phase, you can say these are the phase of capillary leak. When fever starts subsiding, critical phase starts. So there is a dilemma that fever disappears, but one should be watchful whether patient is passing in the critical phase. One or all of following complication may develop, and if not intervened in time, that may result in fatality. Significant plasma leak, lead or shock, uncompensated shock may lead to death. Hemorrhagic manifestation, bleeding from the several organs or mucosal bleeding, gut bleeding may take place. Severe organ involvement may develop hepatitis, encephalitis, myocarditis, bleeding. So this is very important. If fever starts subsiding, but one should not get relaxed. Rather, one should be watchful for development of these critical phase symptoms and signs. And once you pass the critical phase, then patient goes to the recovery phase. As the patient survives 24 to 40 hours critical phase, gradually reabsorption of the extravascular compartment fluid takes place in the following 48 to 72 hours. General well-being improves, it returns, gastrointestinal symptoms, all the gastrointestinal symptoms are met, hemodynamic status stabilizes, and diuresis ensues. So all together are a good prognostic sign, and these are the symbolic of that patient is in recovery phase and patient is recovering. So expanded dengue syndrome. What is expanded dengue syndrome? This unusual manifestation of patients with severe organ involvement such as liver, kidney, brain, or heart associated with dengue infections. They are reported by WHO in 2011. Expanded dengue syndrome is also commoner in dengue with comorbidity. Usually it is common in comorbid patients having other comorbidities like neurological encephalopathy, encephalitis, aseptic meningitis, intracranial hemorrhages, thrombosis, mononeuropathies, polyneuropathies, Guillain-Barré syndrome, myelitis, gastrointestinal and hepatic here manifestations are hepatitis, fulminant hepatic failure, acute pancreatitis, febrile, diarrhea, acute parotitis, and acute cholecystitis. Lymphoreticular manifestations are spontaneous splenic rupture. This is very dangerous and almost invariably lead to death. Lymph node infarction. Cardiac manifestations are myocarditis, pericardiac effusion, pericardial effusion. This type of manifestation may take place. Respiratory symptoms, acute respiratory error syndrome, acute respiratory distress syndrome may take place. Pulmonary hemorrhage may take place. Musculoskeletal manifestations are myositis, rhabdomyolysis, and renal manifestations are hemolytic uremic syndrome. and renal failure. So these are the expanded dengue syndromes, and which are always fatal. So that can be managed only in tertiary syndrome or well-equipped hospital, in tertiary hospital. Clinical management, so far clinical management are concerned, it's dengue, the viral disease. There is no specific medicine for this, so treatment based only on symptomatic management, and depending upon the condition of patients and situation, you will have to plan your treatment. So common management of dengue fever is symptomatic and supportive. Bed rest is usually advisable during the acute phase, and use cold tepid sponging is the best to reduce the temperature and keep the temperature below 38.5 degrees centigrade. And paracetamol is a choice of antibiotic to lower the body temperature, but by in no case the aspirin or anti-inflammatory analgesic should be used. That is absolutely contraindicated. Otherwise, they may lead to bleeding, as there is thrombocytopenia. In children, the dose of oral IV paracetamol is 10 milligram per kg body weight, whereas oral is 15 milligram per kg body weight. Encourage oral intake of at least 5 glasses of other fluids with electrolytes in addition to normal daily intake of plain fluid. That is the best management you can suggest in your outdoor patients. Simply paracetamol, tepid sponging, and plenty of waters is the treatment, is the suggestions given in the OPD. Small frequent sips of those with nausea and anorexia patients should be monitored for development of complications till 24 to 48 hours after they become febrile. Fluids to be taken and to be avoided is listed here. Fluids to be taken: fruit juice, coconut water, ice water, barley water, oral dehydration solution, soup. Fluids to be avoided are commercial carbonated drinks, that is the cold drinks, drink that exceeds the isotonic level, more than 5% sugar. What should be done and what should not be done? To be done: adequate bed rest, adequate fluid intake, take paracetamol, tepid sponging, look for mosquito breeding places in around and eliminate them just to prevent them. And what should not be done: do not take NSAID like aspirin or brufen or any steroid combinations, or paracetamol in combination with NSAIDs should be avoided strictly and should never to be taken. Antibiotics are not necessary, as it is a viral disease, it is of no use. Choice of fluid will be use isotonic or isoosmolar fluid. It should be given, and preferably crystallized, but in critical phase you can give these colloids to just raise the blood pressure, restore blood pressure. And use a hypotonic solution. Hypotonic fluids must be avoided. So no hypotonic solution should be used. Colloids are used in case of hypotensive shock, and repeated shock to second and third shock onwards after more than 20 to 30 ml per kg of crystalloids. You can give these colloids. Dose limited to 30 to 50 ml per kg per day. Summary of IV fluid therapy is inadequate, adequate, and excessive. If you are inadequate, then certainly there won't be benefit. Hypovolemia, decreased tissue perfusion, compensated shock, hypotensive shock, bleeding, DIC, multi-organ failure. And adequate is the best. You give the adequate fluid, improved circulation, capillary refill, less than 2 seconds, it refills, normal heart rate, normal blood pressures, and pulse pressures are restored. Urine output comes to 0.5 ml per kg per hour. Hematocrits goes down to normal, improving acid-base balance. And if you are giving excessive fluid, then there will be fluid load, particularly in recovery phase, where there is plasma reback, fluid comes reback to intravascular compartment. Here one should be cautious, and fluid transfusion should be decreased gradually, so that to prevent pulmonary edema, respiratory distress, worsening pleural effusion, and ascites, clinical deterioration. Maintenance fluid therapy, just meant for maintenance. Once you manage the shock phase, maintenance is just 10 milligram per kg body, 100 ml for less than 10 kg, and for 10 to 20 kg, you can go for Rext from 11 to 20 kg. It is 50 ml per kg body weight. So it will be around, for 20 kg, it will be 1500, and for more than 20 kg, for every, in that should be 20 ml per kg, means 21 kg above. For every kg, you will have to give 20 ml per kg. So by this way, you can calculate the maintenance fluid dose depending upon the age. So prevention, what prevention should take place? Certainly prevention is better than cure. And how this dengue spread can be prevented? Certainly if it is a mosquito borne disease, vector-borne disease by Aedes mosquito, so you will have to prevent this Aedes mosquito, their breeding and their bite as well. So most best way is to use save yourself from mosquito bite, because it is very difficult to control this mosquito breeding, because that requires a multi-department involvement. But it is better to save yourself by mosquito repellents, and some other effective repellents include mosquito patches nowadays available. This can be used in the back of clothing. Repellent bands are available. These are waterproof silicone bands that are infused with citronella and prevent mosquito attacks. Mosquito wipes are there that can be used, and it is better for kids. Wear protective clothing. It is the best. Always use full sleeves clothes. And during mosquito seasons, it is advisable to sleep in room with air conditioning and windows over covered with mosquito nets. So even if and mosquito is this Aedes mosquito is a day biter as well. So even if you sleep in in daytime also, you should use mosquito net. Mosquito deterrents are some new things when cleaning your house. Use cleaning solutions, and some electronics devices are there that keeps this mosquito away. Refrain from breeding grounds. So this mosquito breeding sites must be, there should not be any potholes, or if there is any lowlands that must be filled up. One should not allow waters to get stagnant, and one should not allow this to flourish as a mosquito breeding sites, particularly if in rainy season, before rainy seasons, avoid using, throwing unused buckets, unused, uncovered these pots or these useless tires, because that accumulates water, and when rainy water gets stored in that, and that gives opportunity of this mosquito, these spores to just go down, to breed. So these type of things, these type of changes, one must take place. One should not be just habitual of just unnecessarily just accumulating these useless pots and unused containers over their roof or in their premises, house premises. So avoid this, collecting this, because this may be the potential source of breeding place of this Aedes mosquito. And particularly if you are using cooler, change water frequently. If you are very fond of this gardening, then don't allow the water to accumulate in these pots. So that measures you can take. Avoid smells that attract mosquito, particularly sweets and perfumes that attract mosquito. Flames are often to remove sweet. So these also attract sometimes mosquitoes, so that you can take care of that. Make sure your home is well lit. Mosquito usually breed in a small dark place. Have the sun stream through the window, and all the ensures your home isn't inviting mosquito in. So in metros, particularly in metros, one should take care of that, whether their balcony is having plenty of sunlight or not, or whether they are deprived of it. So while choosing your house, you must consider this. Be knowledgeable about dengue fever, and it is always to be aware. Awareness is the best way, and prevention is the best way to get rid of disease, get out of disease. So dengue fever is caused when the virus is present in the salivary glands of the mosquito and are transmitted to humans by mosquito bite. So it is better the virus enters the bloodstream resulting in viremia. So always prevent yourself from mosquito bite and prevent mosquito breeding. Just prevent your premises with this mosquito breeding sites by taking small measures, as I discussed. And always it is best to uh, use full sleeps whenever you go out, and even in day or in office hours, you use full sleeps, and keep your premises, keep your house or keep your office working house mosquito free. That is the best way if you want to avoid dengue, because it is spreading day by day and it's now threat to the society. And so far practicable, better prevent these villages from getting urbanized. Suburban areas are now most potential threat for this epidemic outbreak. So that's the threat. I hope I have been able to communicate. That's all. Thank you very much.
Thank you very much, sir, for this nice presentation. Am I audible, sir?
Yeah.
Okay, sir. Just one. Yes, sir. So, sir, if you allow, then we can take the questions.
Yeah.
Sure. Sir, one question is, in case of high-risk pregnancy, if one lady is got this dengue virus, so how to tackle in that situation? What are the precautions need to be taken, or what are the drugs can be prescribed, although it is in high-risk pregnancy? So, what is your opinion on that?
See, in pregnancy is you can say it's a normal physiological condition, so you can't avoid it. And if particularly pregnancy is such a thing that gives a dilemma while dengue is there or not, because pregnancy itself causes vomiting, and dengue's warning sign is also vomiting. So one should not get confused with whether it is due to dengue or this is due to pregnancy. So it is always better, if you get fever in pregnancy, if facilities are available, then better to get it admitted and screened for this and watch for this. And particularly in high risk, suppose there is uh, chances of bleeding is there, and particularly in those high risk patients, high risk pregnancy, somewhere where you are using aspirins. But first of all, you should stop this using aspirin if there is dengue, and you should go for regular hematocrit values, and you must uh, uh, say the patients to take care of it. And particularly dengue is more risky when it is in the later part of pregnancy. If it is in the early part of pregnancy, then mother develops antibody. But if in the earlier it is nearer to the delivery, it is more dangerous, and this may also lead to neonatal dengue through this transmission. So these are the things one should keep in mind, and particularly fluid overload is in pregnancy already, and while treating that, you should take consider whether you are taking consider of this or not. So by regular hematocrit examination and proper taking care of proper medications and getting aware of it, you can say if a pregnant lady resides in the area where dengue is prevalent, then she must take care all this and must avoid this mosquito bite. And if at all fever develops, without any delay, that should be taken into consideration until unless prove otherwise. That should be treated as dengue patient.
Thank you very much, sir. And one question is, sir,
Yeah.
sir, in case of cardiac ailments, if already there is an imbalance in the electrolyte or some problem, so what is the approach? Because in case of dengue, as we know, there will be some fluid has to be given. So, what is your opinion in case of the cardiac or urinary ailment patient?
See, in a cardiac patients, obviously, for you should go for a proper electrolyte measurement, and accordingly, you should treat. Regular electrolyte balance must be there, because even if a small imbalance may lead to catastrophe there. So, in cardiac patient, without doing electrolyte, one should not go for this blind fluid therapy. I think accordingly, as the electrolyte needs there, accordingly over fluid, there is always be a catastrophe. So in that case, depending upon the demand of the heart, you have to take consider of.
Thank you very much, sir. And sir, is there any means when to consider this is a hemorrhagic shock? So, any parameters and limits?
Yeah, hemorrhagic shock. See, it is very important to take meticulous study of this dengue fever. If you are very meticulous, usually this hemorrhagic shock takes place. Usually, this in critical phase there is a shock, but in that is due to plasma leak. But if there is this massive thrombocytopenia, if it is below 20,000, we take consider below 50,000, but usually hemorrhage takes place below 20,000 if platelet goes, and that is a potential threat for this hemorrhagic, and by you can assess the shock by this. If you are applying the simple methods, simply capillary filling is can you give you the idea, but you can go by other volumetric measurement as well. If you are in tertiary setup, you can go for this central venous pressure management as well. Mainly, you can see with if there is patient is pale, if there is patient cold and clammy periphery, and if there is capillary refilling time is more than 3, then you must consider that patient is passing into hemorrhagic shock if there is thrombocytopenia existing. And accordingly, you can just go for hematocrit value assess, and then you can diagnose this hemorrhagic shock. If there is a obvious bleeding, then there is no question. If there is internal bleeding, then these are the measures.
So thank you very much, sir, for this nice presentation and obviously for the deliberation.
Okay, thank you, Sumanji and your team, all the SEAL team, for giving me the opportunity. Wish everyone get rid of this disease and get aware, and we should get aware of this and prevent our society of this fatal disease. Thank you very much.
Thank you very much, sir, for having you to discuss on this very important topic in our platform Field Connect, and in future also we would be very happy to organize such kind of important session on the platform.
Okay.
So thank you very much, and have a good day. Good day, sir.
Thank you. Wishing you a Merry Christmas and Happy New Year.
Thank you, sir, and thank you all of the delegates who have also joined. A Happy New Year and Merry Christmas to all.
Okay.
So thank you
to
very
all
much.
the delegates, yeah, it's our sincere wishes.